in cardiology who has been asked, and he has accepted an invitation to serve as a member of an NIH study section, the Systemic Injury by Environmental Exposure. That gives visibility to us. It tells you how the strength of our people in cardiology, and of course Dan is a great guy, so hopefully he'll represent us well in that group. Before we introduce Dr. Bowley to introduce our speaker, a couple of comments about a number of people to remember today. First of all, Cho Hao Li was born on this day back in 1913. He was a Chinese-American biochemist who was also an experimental endocrinologist, and he's known for having isolated and purified 6 of the 8 known hormones secreted by the anterior pituitary gland. We also remember Rita Levi-Montalcini. Roberto, do you know Rita Levi-Montalcini? So she was an Italian-American neurologist who shared the Nobel Prize for Physiology of Medicine in 1986 for her discovery of nerve growth factor. And in World War II, Mussolini's law, she was not allowed to pursue an academic career. So she actually established a small laboratory at her house where she studied nerve growth in chicken embryos. So that's outstanding. Now, today is about measuring pressures, and temperature is important and all that kind of thing. So we remember Percy W. Bridgman, who was born on this day back in 1882. And he was an American experimental physicist, actually the first Harvard physicist to receive a Nobel Prize in physics. And he did his studies on pressure and high temperatures. However, this is Cardiovascular Day, so we should remember Jean L. Poiseuille. Are you going to introduce Jean L. Poiseuille? If not, then I'll introduce him. And he was born this week back in 1797. He was a French physician and physiologist who contributed to knowledge of blood circulation through arteries, and he developed an equation describing the laminar flow rate of fluids through narrow tubes. This is called the Hagen-Poiseuille equation, because Dr. Hagen actually discovered it independently. And it relates to flow rate and to the fluid's viscosity and so forth. So he was very interested in circulation of the blood. He's believed to be the first to have used the mercury manometer to measure blood pressure with his invention. So we remember that today. And with that, I'll leave you with Dr. Roberto Bowley, who's going to introduce our distinguished guest.
Good morning. I'm pleased today to introduce one of our recent additions to the Division of Cardiovascular Medicine, Raj Vijayakrishnan. So Raj graduated in India and then came to the States for training, did his medicine residency at St. Vincent Hospital in Western Massachusetts and a cardiovascular medicine fellowship at the Geisinger Medical Center in Danville, Pennsylvania. He then went on to receive training in heart failure at the University of Utah in Salt Lake, which is one of the major centers for advanced heart failure and transplantation. We recruited him last summer to join our growing program in heart failure, and we recruited him because of his training in one of the top centers in heart failure and transplantation, and also because of his obvious academic and scholarly interest. He has published 16 original papers and 2 reviews, which is quite remarkable considering the early stage of his career. He was recruited because of the growth of our heart failure program. And talking about growth, this is one of the success stories of the department. When Jesse arrived in 2009, we had 1 heart failure cardiologist. And in fact, for many years, we had none. And today we have 4. We have an outstanding group, the only heart failure transplant group in Kentuckiana, and certainly the best in Kentucky. So we are very pleased and very proud of them. And Raj will definitely contribute to the growth of this group. He is in charge of several aspects of the ventricular assist device and transplant program, sits on many committees, and has already made important contributions, and we look forward to his continuous growth. Today he will discuss invasive hemodynamics inpatients versus outpatients.
Thank you. You can hear me, am I right? Thank you for the No? Okay. This is better? Okay, thank you. So thank you for the generous introduction. Today we will talk about invasive hemodynamics, inpatient versus outpatient monitoring systems. Start the timer so I don't exceed the time. So the main important thing we need to know is that no money, so no financial disclosures. And we need to first know what is the importance of this topic. So why we talk about this? Because it was sort of squashed in 2005 with a lot of papers. So why am I bringing it up again? The reason is simple. The knowledge about RA and pulmonary wedge capillary pressures are important. And why is it important is because of this simple table. As the RA pressures go up to like 16, the hazard ratio is 1.6 times to die in the next 6 months. And also, when the pulmonary capillary pressure goes above 30, the hazard ratio is almost double. So this is also the survival of people just got admitted, had a measurement, and that is very important piece of information, which we know. This is objective evidence, science. And then we go to the next question. Why do we really need those numbers? Why don't we just use our age-old skills? Now, they compared the skills, the fact that you can hear auscultation with the S3 or RALS or ascites, edema, orthopnea, hepatomegaly, jugular reflex, JVP measurements, all of them. Very interesting thing. When the sensitivity goes up, specificity goes down. When the specificity goes up, sensitivity goes down. And then the predictive values are all, nothing is really consistently high on both sides, negative as well as positive predictive values. So then we say, okay, why is that so important? Because most of the physicians don't deal with this kind of advanced disease. Now, there are a lot of ICU patients who come in with pressures are like a little bit lower, maybe even lower, like hypotension. People have fatigue symptoms, cold extremities, cold profile. All these things are important in the prognosis of patient getting out of the hospital as well as staying alive after getting out of the hospital. So when you look at that, again, sensitivity is low, specificity is high. Sensitivity is high, specificity is low. So this is being an ongoing issue, and the predictive values are always being like that too. So we need to understand in Cox regression analysis, the discharge cold or wet profile conveyed a 50% increase in death or rehospitalization. And now when we look at all these things, when you average all these things, it's a 50% sensitivity and 50% specificity. That is meaning, I asked two physicians, do you want to guess? Maybe yes, maybe no. So basically, nobody knows how to do this properly with all the best clinical acumen you have. And this is not me saying, because I am just 37, I don't know medicine much. But if you ask somebody who is 70 years old, has been doing this very well, they will say the same thing. It's fleeting. So then before we go into the dynamics part, I just want to shed a little bit light on history. I didn't go all the way back to the actual physics principles because I thought maybe a little bit redundant and a little bit of confusing for people who are not interested in that. So I skipped Poiseuille. Even though Bernoulli, Poiseuille, Hagen, all these people are very important in the dynamics of what we now call as cardiovascular physiological dynamics. So goes with Stephen Hales. In 1711, he actually placed catheters in the right and left ventricles of the living horse. But he didn't get much to the physiology part. He just put it there and showed that in a live animal, you can put those catheters there without killing them. And in 1840, almost a century later, Claude Bernard was the first one to study the cardiac physiology. And that was an animal model too. So then it came to the era of X-rays. It's interesting. I thought it was William Röntgen all the way, because that's what we know, always Nobel Prize winners. But more to that is William Crookes and Jonathan Hittorf, who developed the Crookes tube. This is the one which actually helped devise the X-ray detection. So everybody detected X-ray based on this device. And Fernando Stanford, when he was studying in Germany during the same time where William Röntgen was also doing his research, found that he could generate and detect the X-rays, but he was a little late in publishing. He's the guy who was a co-founder of Stanford University. So if he had published a year earlier, probably it would have gone to him. But William Röntgen was into it, and he actually first published the X-ray detection and use of them. And independently, a Polish physicist, Ivan Pielo, he also published the data, but it was completely independent of the German study. Again, timing is important. But the first medical use was in 1/11/1896 by John Hall Edwards. I couldn't find a picture of him. He did it for X-rays in the hand, so that's what he used it for. But we had to wait maybe 30 more years for angiographic evidence. So they used X-ray for angiography, first time in cerebral angiography by the Portuguese physician Egas Moniz, this gentleman here. And he used it for cerebral angiography and proved that that could be used medically for things more than bones. And also the most important thing, which in a cardiology standpoint is cardiac catheterization, 1929, William Werner Forsman. It's a very interesting story. I can talk about him for half an hour. So he actually was almost fired by his boss for doing this. He actually placed a Euro catheter because his wife was a urologist, so he took a catheter, placed it in antecubital all the way to his right atrium, and ran up the stairs, 2 flights of stairs, went to the X-ray department, took the picture, showed it to his boss, and he said, if you keep doing this, you're fired. So finally, he was pushed back from the cardiology field and had to become a urologist. So always an issue. But he kept on doing his studies in 1930s, used the Fick method to calculate the output. And Andrew Conrad and Dixon Richards, these two gentlemen, actually modified these techniques and actually went into the ventricle and got more pressure measurements. And hence, in 1956, 3 wise men got the Nobel Prize. All the 3 people shared the Nobel Prize for devising coronary, not right heart cath, basically, not coronary angiogram. So that is the story. But the things which we know now is based on the Fick method as well as thermodilution. And the credit goes to Arnold Prochnik. Actually, he is a Cardiovascular Institute in Prague, is Czech person. He actually devised the technique of thermodilution, which is commonly used in the ICUs nowadays. And Bradley actually simplified by using a simple Portex tube rather than the stiff Euro tubes which they were using before. And it was Jeremy Swan, actually, who modified the tip of the balloon. The first time I heard about Swan, I thought it is because the swan is being floated, so it's called Swan. Then I realized that that's the name of the guy. And then I realized that he just did one thing, just put a balloon at the tip. You know, that's genius. And that actually improved the insertion of these tubes to a very, very safe, like 0% mortality kind of procedure. William Gans actually was working with this guy over there, and he actually introduced a small temperature probe around 3 centimeters behind the tip, and he actually got the credit for the Swan, which we know now, Swan-Gans catheter. There were 3 people. Bradley was there, but always, if you want to invent something, make sure it's in the first 2 names, because the third name is always forgotten. Now you need to know a little bit about the technique. Everybody knows it's a little bit interesting. So this is the thing which is in question. We have a balloon contributed by Swan, and a thermistor which is somewhere here, which is contributed by Gans. And then we have the balloon port, we have the proximal port, which is in the RA, the filament port, which is in the RV, and the infusion port is in the RV. This is if you have an extra port for the filament measurements. And you have the distal port, which is over here, the tip, and the thermistor is over here. Usual length is around 100 to 110 centimeters, and the proximal port, as I mentioned, is 30 centimeters from the tip. This is an important piece of information because usually if you don't have a heart disease, this is perfectly placed. If you place it in the main PA, the RA port will be in the RA. Most of the patients I see, or in the heart failure clinic we see, they have a ventricle which is the size of a soccer ball. So that means this 30 centimeter rule won't be good because of the extra length. The RA port may be in the RV. So we have to be very careful when we do measurements in these situations. And as I told you, venous port is in the RV, thermistor, balloon, and distal. So simple. And zeroing is a very important technique. The device is only as good as the way you do the technique of insertion and measurement. So we usually make sure it is in the mid-RA, And how we usually do is we lay the patient down, make sure it's use the phlebostatic axis, which is halfway between the anterior and posterior chest, and fourth left intercostal or fourth right intercostal, whichever you want to pick one, and the zeroing should be done at that point. There are certain modifications we use, whichever is that we have to have a standardized protocol in all the labs to have consistency. And you can even do it when the patient is upright. Just have to be very careful with the data we get from there. And this is a rough estimate of what the pressure waves look like when we put it in different parts, in the RA, RV, PA, and the wedge. So calculations are very important. Previously, a lot of physicians here might know that how you calculate is sit there with a pen and paper. I think that's a little better than the electronics now because they are very inconsistent. And since I work in the cath lab, I know the pain of that. And the technicians who work with me know the pain too, because we still use pen and paper. So a few things we need to know. SVR, which is mostly for the fellows in the room, the attendings pretty much know these numbers. 80 times the pressure difference. That is a MAP minus the mean arterial pressure and divided by the cardiac output. And the pulmonary vascular resistance is the same. The mean pulmonary pressures minus the wedge pressure divided by cardiac output. And cardiac index is cardiac output by body surface area, and stroke volume index is divided by the heart rate. So why it is important is because of this one thing. These are important facts. I'm not going to go deep into that. These are the work indices. It's a little bit more for advanced learning, but most important is oxygen delivery. We assume that cardiac index multiplied by 13.4 multiplied by hemoglobin into aortic saturation is the oxygen delivery, and the oxygen uptake is the AV difference of that. This is important because that's what the Fick method is, or the assumed Fick method is. We'll come across that. So Fick in 1870 actually devised this formula and used usually a water hood for a non-ventilator or metabolic heart for a ventilated patient to actually calculate the number, which can vary a lot. This is based on the conservation of mass, which now we know is not completely correct technique. So Bernoulli's, Poiseuille, Hagen, all these equations are good in a stiff tube with a good viscous fluid which does not change viscosity, which is not blood, which is not arteries, which is not human body. So you need to know all the principles based on which the physics are being defined are not completely reflected in human situation, but we do the best we can. We use the formula that oxygen consumption is equal to cardiac output multiplied by AV difference. And we know the oxygen consumption formula, which I just mentioned, is 130 into BSA divided by 1.636 into hemoglobin per 10. So the thing is that how do you get this number, which is a constant? And I'll come across that. And this is in the assumption that there is no shunt, and there is the VO2, which is the actual mixed venous, is the PSAT, which is the distal port of the Swan catheter. So either do this way or this way before we do it, but we don't have time to do it. The cath lab will hate us, and the ICU people will kill us if we keep doing that. So then we need to know what this definition of these normal values, which we assume is normal. So the mean RA, we assume that 5 or sort of 5 is normal, and when you go all the way to 16, it is very abnormal. RV, diastolic, again should match the RA, so it should match. Systolic should be around 25 at the max, and when you go to PA, PA is very important for pulmonary hypertension reasons as well as heart failure reasons. We know that the PA systolics and diastolic should be around 30 by 15 at the max, and PA mean should be less than 18 if possible to be as a standard of practice. Different labs are different. This is from where I got trained at the year before when I was in Geisinger, they had a little bit different value. So every lab has a little bit different section, but they are roughly the same. If you go to a WHO definition, 15 is good, and less than 25 is considered as not abnormal. And wedge is less than 12 is considered as normal. Now, these are the waveforms, how it looks in the RA, RV, PA, and wedge. If you go to the textbook, this is what they give as a range of normal pressures. Now, diagnostic accuracy is very important because this is the diagnostic test, and accuracy is the most important part of the game. So now let me tell you about the assumptions in FIC calculation. We assume that AO saturation is the oxygen saturation. Ideally, we need to have simultaneous measurement, but that's like a more invasive procedure, and it has to be done at the same time, syringes by two different technologies. We presume that the PA saturation is mixed venous because ideally it is mixed venous at rest is 3 times SVC plus 1 time IVC, the whole divided by 4, or if your patient is exercising using the legs, then it is 2 times IVC and 1 time SVC divided by 3. So this is another assumption we do, which is most of the time very close by. Doesn't change the numbers very much. We assume it is a steady state. The patient doesn't move, patient is resting completely, is not under stress, not having high blood pressures and all these things. We also assume that the oxygen consumption is an assumed number. If you look at the actual number, the variability is 71 to 171. It's like one side to the other side. We assume it is 130 so that there is a standardization across the board. That is why we use a number specific. Otherwise, different labs will give you different oxygen saturations on the same patient if it is done simultaneously. We try to keep it standard. We're working with McKesson to get it done. We fixed it, then they stopped, and then they're doing whatever they want to do now. So, challenges is the cardiac output using thermodilution. This is one thing which we do bedside, and we're very careful with this thing. Previously, they used to use cold saline at 32 degrees Fahrenheit. Not 32 basically, it's 4 degrees Celsius. So they used that, but then they stopped using because it warms to 1 degree Celsius or every 28 seconds. So by the time you go from one side to the other side, it's 1 degrees are different. So they now use room temperature. And the thing with room temperature is that is still lower than your body temperature. So you shouldn't be holding on to the body of the syringe which you're using to push the fluid to measure. So this is one thing which the nursing staff has to be reinforced. We reinforce the fellows to do it correctly. Irregular heart rate is a problem because we assume everything is steady state. Tricuspid regurgitation, high PEEP, worsening tricuspid regurgitation, again a problem. Low output stays, more mixing occurs, so we may think it is spuriously low. So it may be showing a lower number than what it is, if it is a low output state to start with. Then the PA temperatures, blood temperature may vary with respiration and with cardiac cycle. So ideal situation is patient is sedated, intubated, and paralyzed. You do this, you get the actual number. You cannot do it in all patients, though. So the other things are, like as I told you, like the advanced heart failure and the heart failure doctors here knows that the RV is not always textbook size. So when the text size is more, there may be inaccurate placement, it may flip back in, so always look at the waveforms before you do any of these calculations. We can always use a 025 wire to make it go to the actual place and do the procedure. Shunts are always a pain. So left to right shunt, there is increased volume and the injected will be diluted, and the right to left shunt may get the fluid from the right side to the left side, so you will be overestimating the numbers. So those are the problems we face with the technology we have. Special considerations are also to be done with these situations. Namely, what happens if the wedge does not match the LV-EDP? The goal is to think that we think they are matching, but there are situations where they don't match. Like wedge is more than LV-EDP in stenosis, mitral stenosis, left atrial myxoma, PE, mitral valve, regurgitation lesions, pulmonary veno-occlusive disease, where we cannot assume that the circuit is complete and without any obstruction or masses in between. A wedge is less than LV-EDP when you have decreased LV compliance, ballooned out things, and we have high LV-EDP more than 25, it may not be transmitting properly. It will be still sort of accurate, but not good. Aortic valve regurgitation, again, there's a problem because the LV-EDP will be little higher than what is being measured as a pulmonary capillary wedge pressure. Because the mitral valve is okay, but the LV-EDP is high, it's not transmitted. Conditions in which wedge does not approximate the LA mean pressure. It's like more than 4 millimeter difference is when you have increased pulmonary vascular resistance for reasons other than cardiac causes. Pulmonary hypertension, core pulmonale, PE, Eisenmenger syndromes, all these situations, the matching won't happen. So then we need to know the interesting part, practical aspect. So when we had this technology in the early 1960s, 70s, it was one of the new things, cool things. Everybody in the ICU has to have one. So that's when the problem started. So everybody usually adopted it like, oh, my baby. So they started using it, and then everybody who got into the ICU with some sort of shock got a device. And then their problem happened because half the people didn't know what to make out of this. And they also extended to post-ACS cases. So anybody has a heart attack should get one. So everybody and each and everybody who was in the unit had one. So if you walk in the unit during those times, every other bed has a patient with a Swan. And that caused some trouble. People started looking at the data of how we are using all these things. So there came the major trial called Support Trial. That was in 1996, the year before I joined med school. So 5-hospital prospective non-randomized controlled trial from 89 to 94. It studied the use of right heart cath data in the first 24 hours of ICU. So they had a patient come in ICU, they put a right heart cath, the Swan measurement, PA catheter measurement, and got the data. That is the study. So the population was acute respiratory failure, COPD, CHF only 10%, just imagine. Cirrhosis, non-traumatic coma, my God. Colon cancer, metastatic to liver, non-small cell cancer to lung, stage 3, 4, multi-organ system failure in malignancies and sepsis only, not in cardiogenic issues. So they found that this was the bread and butter in the ICU most of the time. Heart failure was less in those situations. They found that when you use the right heart cath versus no right heart cath data, there was a 30-day mortality which was in favor of non-right heart because most of the time it confused the physician rather than helped the physician. Cost of care almost $15,000 more in 1996. Length of stay was similar. It just confused the physician for 2 days. So that's what I take from this. But they never kept this for more than 24 hours. They didn't use it for managing the patient. So my question is, why do you use a technique if you don't use the results of it? You know, that is the biggest backdrop of this trial and all the trials which are coming after this too, because nobody knew what to make out of the data we get. Now you go to Pacman Trial. This is a European trial where they compared PACs, that is pulmonary artery catheters, 519 patients to 522 without PACs. And they found that the hospital mortality was similar in both the groups without any difference. And insertion complication was one of the big things. Or people who hated Swan said that, oh, the people are going to die. Nobody died in that study. Nobody died in the study. Complications are mostly pain, bleeding, and infection if you keep it for too long of a period. The limitation, again, of this study is important. The timing of insertion, subsequent clinical management were at the discretion of a treating clinician. There was no standardized protocol. If I walk in, I think it should be done. Okay, if somebody else walk in, say, no, you don't need it. 2 days later, we'll do it. We do it. So there's no standard protocol to see when how to start the use of this device. ICUs also used other methods to monitor the cardiac output. So even though you say control is without PAC, but control uses some information which we are getting from the PACs. So it is not placebo control. It is controlled to some other variables. So that may skew the results we get also. Then poor waveform identification by the staff was one of the most important thing in this trial. Like there was no guidance. There was no standardization. Okay, if you ask 10 people what the wedge is, they have at least 2-3 different answers. So that is always a problem. And again, heart failure population is less in this trial. But this actually is important because that was the standard of practice in the ICUs across the world to just use it on everybody. Then came the ESCAPE trial. So I was all bickering about the fact that there was no heart failure patient. This is for heart failure patients. This is 433 patients in 26 centers. It's an American-based study. So it actually did target both groups, resolution of clinical congestion as well as targets of normalization of the pressures like pulmonary capillary wedge pressure 15 and RA of 8. The problem again here is medications were not specified. So University of Louisville can use something, Cleveland can use something for the same data they get. So, and then they said, hey, you get somebody in shock, but try not to use the inotrope. How good is that? So again, the problem was there. They pushed for not using inotropes because when we use inotropes, we know that they come with its own side effects and adverse effects, which may skew the trial data. So it was a little bit of a discouraging thing because you cannot technically do a proper trial on these patients. And I'll come across why it is so. And also they excluded end-stage renal failure or end organ damage, basically, creatinine more than 3.5. And if the patient needed dobutamine, dopamine more than 3 or milrinone, no, they are not in the study, which was again surprising because they are the ones who really need the Swan. And when you look at the baseline characteristic, just ignore that. They are all pretty similar baseline characteristics, so none of them were very significant. Creatinine was a little bit different, but that was because of the registry data difference. But if you had to just look at these two numbers, they are pretty much matching each other. So then they go into primary endpoint. The primary endpoint was days alive out of the hospital during the first 6 months. So it was similar. There was no difference. And secondary endpoints were exercise, quality of life, biochemical markers, and echo data. So when you go there was always a favor towards PAC and clinical judgment when compared to secondary endpoints. Only clinical assessment, it didn't favor at all. But again, that is not a strong favor. It is a sort of a favor, that's it. When you go to subgroup analysis, what we can understand from the trial is that if you have a patient who is older than 65, a female, and if the cardiac index is normal, you will, or the site enrollment is high, that is high volume centers who know what to make out of these Swan numbers, they have better prognosis. And that is interesting. Mostly because of the fact that once you have cardiac index going less than 2.2, we know that the mortality by itself is very high. So how are we going to increase the survival in those patients is always a question. So again, use of milrinone was an issue, use of inotropes was an issue in this thing. Again, the limitation explicitly mentioned in this study that there is a lack of definition of precise strategy in response to the hemodynamic information we obtained from the study. So you can have all the data you have, but there's no standard. Okay, what are we supposed to do if your RA is 20 versus 10 versus 15? Nobody knows. It's depending on the institution and the physician who is standing in front of the patient with the catheter. That's what it was. And there was considerable variation in the use of medications, as I mentioned. Secondary endpoints, there were a lot of data which was missing. So we don't know what actually it means. And most compromised patient population to be ever studied in an NIH-granted fund, NIH-granted study is this one because it has a 19% mortality in 6 months. So how is it possible that we can assume that a diagnostic test can improve the survival in this patient, irrespective of what the test is, unless and until you have what you call venting. Venting means you need to know you have a patient who is going to die, you have a plan to save the patient, other than what we play with the medicines, like a VAD or a transplant, ECMO, any of those things. If you don't have venting plans, we cannot say that we are going to improve the mortality of any patient, because ultimately these patients are in the, what we call in cardiology department is that they are off the cliff. We just have to know how far they are down the cliff. So we just need to know that unless and you have those plans, we cannot say these techniques will be useful. So then they did, in the same year, in the same article, JAMA, they did the meta-analysis of all the randomized control trials so far. So they did all these searches, and they did the study selections were perioperative ICUs, advanced heart failure, ARDS, sepsis patients. And what they come up with is 13 randomized control trials. The support trial was not included because it was not a randomized control trial. And the ESCAPE trial was part of this one, and they found 5,000 odd patients. And conclusion was in critically ill patients, The use of PA catheters neither increased overall mortality or days in hospital nor conferred benefit. And this is driven mostly by the fact that we didn't have vending. We used in patients who potentially did not need it, and kind of things. And the limitations, again, is this. PAC was a diagnostic tool only. Expectations to improve a survival without therapeutic interventions is highly unlikely and unrealistic. And use of different types of medical surgical conditions, and so you cannot compare one study with the other, or even in the study itself, you cannot compare the utility. Diagnostic accuracy have led to more use of more inotrope and vasodilator in some of the studies in this meta-analysis, but they by themselves are known to have side effects. So that will skew the results we get from these trials. Now, no major standard guidelines on what to make out of these numbers. And percent of patients in heart failure low in all the studies except ESCAPE trial. And in ESCAPE trial, they were too sick, and they didn't do anything with the data they got in the trial. So, and ESCAPE trial is important because that is the only trial where the staff was trained to look at the waveform and say, this is the waveform, this is the wedge, this is the RA, this is the mean, all these things. None of the other trials had any kind of control, quality control on how to assess these numbers or waveforms. So that is a big part of the thing. It's like first week of my echo rotation trying to do a TE. Well, good luck. That's how it was. So now, again, we need to look at the barriers of use of this technology. Most important thing is that people shout that, oh, people are going to die, there are a lot of complications. No. It's like 0.1 to 0.5%, and none of them are fatal. They are mostly bleeding and pain issues and some arrhythmia. You can always pull it back. It's not the end of the world. But people always shout about that. Ability to measure similar variables while less invasive measures have been used in studies, so they say, why don't we use that? But to date, there is no other technique to measure the pulmonary capillary wedge pressure other than putting a Swan in. You can do it other way around. We can do a LVEDP measurement through to the left side, but short of that, I don't think I know anything about any method to measure the pulmonary capillary wedge pressure. They say the cost is high, but again, you have to see why is that cost high is because they didn't use this for anything. They just put it in and then took it out. So it's like somebody comes to the ICU and for some GI bleed or something with anemia, and I'm doing a CT of the head for no reason, and then say CT of the head is not useful in ICU patients. Yeah, but like you did it for a wrong reason, like why do you do a CT of the head in a patient with a GI bleed? Those kind of things. So speculation is not a good idea to say what the cost is actually. Lack of advanced ICU support team is a very important factor, especially in low volume centers. These kind of measurements should not be just randomly used. This kind of a technique should not be randomly used because they don't know how to make adjustments in medications. The most important thing of all the thing is that if you do a study on 31 item examination of PACs, 67% of the 500 or North American physicians only completed them. That means like 30% of them didn't even know how to complete the 31-point questionnaire. And if you look at more than 1,000 critical care physicians, not regular physicians, critical care physicians, only all the 83% were able to answer these questionnaires. Only 2/3 were able to identify the wedge pressure. That means 1/3 were guessing or they were wrong. So just imagine if Dr. Roman knows how to do it, he goes in, he starts a Swan catheter, and the next person comes in who is not a big fan of Swan, and just like me, just coming out of the fellowship and then say, I don't know what it is, so I will do something. And then the next week somebody else comes. So this is the problem. Like every third person is not going to know what it is. So experience is very important in these situations. And you have to have more of a group discussion and staff meetings. And staff meeting just doesn't mean staff of physicians, with the nursing staff and technology staff to make sure these numbers are accurately identified and we have a plan set in motion to do the management based on the numbers. So again, now we say about physician. Again, the critical care nurses in California had only 57% chance of getting it right, and only 39%, that is 60% of them missed the wedge waveforms. So there's a problem. And they are critical care nurses. They're not regular flow nurses. So probably they've got some training also. Still they couldn't figure out. So this is the most important problem in these techniques. It's only as good as the guy who or girl who interprets the waveforms. Now, based on all the things which I discussed so far, I have few things in my brain thinking that this could be a good indication. Anybody who is in cardiogenic shock, resistant shock of any nature, evaluation and postoperative states like transplants and VAD, and complex congenital heart disease with any form of shock, low output heart failure with any form of end organ failure or dysfunction, where you think Swan may be able to help identify the use of inotropes and afterload and preload reduction. And also the important thing is that even if you have all these things, you don't have to jump and put in a Swan as soon as the patient hits the unit. You can try a little bit of diuretic and a dobutamine or a milrinone or something even without a Swan. You try them when you think it is not going in the right direction or you need additional information to change the management. So that is very important. So both these things as well as don't jump and do something. No reflex physics here. Very important is when to remove these things. And you have resolution of shock, stabilization of primary condition, and as soon as we can get it out, get it out. Never leave it for more than 7 days at the same site. We have policy to change it every other site, every 7 days. And when you think the risk is more than a benefit, don't even think of, just pull it out. Okay. And who should be interpreting is very important. We need to have a staff trained in Swan monitoring. And the program where I trained, they used to have monthly meetings with the physician and the cath lab, make sure the staff in the unit knows how to interpret these things. And Dr. DePhilippis have been doing a great job in trying to educate the people there to figure out, okay, this is what it is, don't just guess things. If you have doubt, make sure the physician is notified on all these things. So this is what we need. I think we need more monthly sessions because of the turnover, and they keep forgetting. If a Swan is not used for 2 weeks, people are going to forget it. High volume center is where it should be restricted to. It should not be put in low volume centers, which is not a problem for us. Trained cardiac intensivists to advanced heart failure cardiology should be into the program, helping the interpretation of this thing. And CCU is the best place, my guess. I could be wrong, but my guess. The new direction now is this small thing here. Okay, it's very small. It's called CardioMEMS. It's an implantable radiofrequency device. So why is this? So this part is the outpatient part. So far we dealt with the inpatient part. This is the outpatient part. So why is it important is because hospitalization is here. You start having symptoms around 5-6 days prior to the hospitalization with the weight gain and the shortness of breath and the orthopnea, PND, all these things. But if you go back almost 25 days prior to admission, you can start seeing the filling pressures slowly creeping up. Okay, and then we have pre-symptomatic congestion, the impedance changes happen. And then 5 days we have weight changes and orthopnea, PND stuff happening. So we always wait. All the clinical acumen is here. We cannot guess this part because this is objective data. So even the best clinician cannot presume that 20 days from now you're going to be in the hospital. If you could do that, you will be a billionaire. So you cannot do that. So why this technique is evolved is because of this one reason. And any device has to be compared with the standard. So they compared this radiofrequency wireless pressure mounting device to Swan measurements and echo measurements on 0 and 60 days and all these days. And they say that diastolic PF pressure is correlated more accurately with Swan-Ganz comparison than systolic, even though systolic was very comparable too. And echocardiography systolic pressures were comparable. So you know that the machine works. So that is very important. And then they did this trial, Champion trial. So the single blinded prospective multicenter trial, it comprised of initial screening of 723 patients, and they landed up finally getting 550 patients for the study. And 270 in CardioMEMS arm and 280 in the control arm, and 26 patients exited out both arms. So that is fair. and 100% participation in both arms for safety analysis, primary efficacy, and ancillary efficacy analysis. So the study was well done. Now, you look at the comorbidities and the baseline characteristics, they all match. None of them were abnormal. All these patients were well beta blocked, well ACE or ARB treated. Aldosterone antagonist was there. Loop diuretics were almost in all patients. And they all had pretty much same characteristics. And the creatinine, everything was similar. So that was a well-run study, if I may say. The target which we were trying to achieve were normal numbers. So normal systolics, normal diastolics, and normal PAs were what we are trying to achieve in this population. And the primary efficacy endpoint was heart failure-related hospitalization up to 6 months. And we see that the 84 treatment group, which is the cardiomyopathy group, and 120 in the control group, and the p-value is significant. And you also look at the primary safety endpoints. Actually, there were no difference. And when you look at the secondary and supplementary endpoints, again, they were all in favor of the treatment group. So this is what we know from the trial. So 6-month reduction in heart failure readmission was 28%, and 15-month was 37% extended. The problem is that we don't start seeing the results from the first couple months because we need to standardize, we need to make sure everything is okay, and then we start seeing the difference. We need to know the trend of a PA pressure. We cannot just say one pressure and the next pressure the next day. It doesn't work like that. It has to be over a period of time that we know the dynamics in these patients. And that is what these graphs show. They all are common first 60 days or so, and then they pan out into significance. So this is the device, 2 millimeter size and thickness and 15 millimeter length, and for total 45 millimeter. And that goes to the left PA branch, and then that is kept here with these wires actually holding it in place. It's a sort of simplish procedure. It's not a big procedure. It's a right heart cath procedure, so it's very simple. And very important is the thing which we need to know in this study is that this is one of the studies which differ from all the studies we discussed so far because they did something with the numbers. Okay, so they did change the medications. In the treatment arm, they almost twice medication changes, and based on signs and symptoms, they are similar, but based on pressures, almost every month one medicine was changed, and that was one of the reasons why the hospitalizations could be avoided. So it's a very intense process. The effect of medication changes on PA pressures were very evident. This is the treatment group because we kept changing things. It started coming down, and the control group remained stable. This is millimeters of mercury changes in the PA pressures. And this is important information we all need to know. In advanced heart failure, the number needed to treat, which is the meat of the game, is this thing. So beta blocker, 7 patients to get that one patient out of the hospital. Aldosterone antagonist, 7. CRT, 7. All these things are high, except for pressure monitoring, which is 4. This is just one trial, so I may not bet on this, but I'm saying if you have the correct selection of patients, it is not like 200 to save to get a benefit. So it is in ballpark with the other therapies we have. So this is what they did. They had the PA pressure measurement, medications were altered, PA pressures were altered, hospitalizations were altered, and quality of life was improved. Very simple logistic. So the indications currently FDA approved is for NYHA class 3 and, not or, and admitted in the hospital for acute decompensated heart failure in a previous 1 year. Now we had to understand, even though they say only class 3, don't get end-stage heart failure patients on this because their mortality by itself is higher and therapies are different. So this is the bread and butter patients we see in routine hospitalization, like patient comes in heart failure. They never mention anything about the EFs, so any EFs are admissible in this trial. Contraindications are inability to take dual antiplatelets or anticoagulation for 1 month post-implant so that we don't have any other issues. Active infection, recurrent PE or DVT, unable to tolerate a right heart cath procedure, GFR less than 25, or you cannot pee. There's no point in doing this medicine because you cannot alter any medications. Congenital heart disease, mechanical heart valves on the right side, coagulation disorder, hypersensitivity to the medications, Dept, CRT implantation within the last 3 months. You don't want to move the catheter and injure the lead. And BMI more than 35 and chest circumference more than 165. So that's out as a contraindication because of the machine which they had to lie to measure it. And if the patient is not willing, you cannot force it on them. This is the team who is going to monitor. Dr. Burks is the PI on the project, and she is the one who is managing the system. And this is me, and Dana is our nurse practitioner who is doing the continuous pressure monitoring through internet. So, and then they come to our offices and adjust. And we have advanced heart failure coordinators in the clinic to help us identify what has to be done, who has to be called, and stuff like that. And they're a big help in the endeavor. And this is our contact details. We are situated in the Jewish Heart and Lung building. And I'm open for questions.
Thank you very much. That was a nice overview of invasive monitoring. I have a question about this CardioMEMS. It's a very exciting technology. So is it FDA approved or is it still experimental?
FDA approved.
Okay, so you can, and how much does it cost?
It's a good question. I'm not sure, but it is completely covered by the insurance. Most of the insurance cover them. And since they have proven that it reduces hospitalization, we shouldn't have any problem getting it reimbursed. So that is my best understanding, but I'm not sure exactly.
So the way it works is that you implant this device and then the patient must come back to the hospital, or can you just monitor him at home?
So patient is given a packet, which is not a packet, it's actually a box, which the patient lays in the bed, and he lays or she lays on top of it, and remotely it senses the pressures, and it is transmitted remotely, and we can get it online. So we have a repository where we get this information and we can see the trends. So patient doesn't need to come to the hospital for any reason. Clinic or hospitalization is not needed. And that is the advantage of this whole process.
So I've been hearing about these wearable monitoring devices like impedance, chest impedance. Would impedance replace this device or obviate the need for this device?
So impedance devices are okay. The reason being, again, they have more contraindications than indications. It can work in an ideal 70-kilogram patient who is young and will do everything without moving. But this is a little bit more foolproof. You can just lay in the bed, and that is easy for all the patients we have. Just lay in the bed and it transmits. So they don't have to worry about somebody else helping them to fit or set up the device. Impedance device, probably I think there may be some need of help from others to help setting up. But here this is just one-man show. The person by himself or herself can do it. So it's a little bit more easy.
Any questions? Andy?
Thank you. Yeah, so sometimes the wedge pressure in a heart failure with preserved EF could be just a volume issue, and a patient who has a heart which is doing this rather than contracting could be an inotropy issue. So we need to identify that, and that's where the help of people who are dealing with day in and day out is useful, rather than somebody who walks in and sees a volume, then diuresis, then you get into more trouble. In the cath lab, we sometimes even have to give volume to these patients to make sure the output goes up. So that is very important part of information to distinguish what these numbers mean from one versus the other situation. Thank you.
Raj, one last question. I noticed over the years, like 30 years ago in the CCU, as you said, almost everybody had a Swan guns. In the last 5 years, I can't remember one patient having a Swan guns. So I think we went from one extreme to another, right?
Yes.
And so now people see a patient with short of breath, they have no idea what the wedge is, and they start diuretics. I mean, who is going to, how are the new young physicians, how are they going to learn? And if we don't train them, eventually the technology is going to go away, right?
Yeah, so that is a very important piece of information, because people are getting more or less comfortable with the device because of these papers which happen. So that is why we need to have a dedicated team in an ICU kind of setting. And even if you have a simple question, curbsiding a CCU attending who is aware of how to deal with this thing will be useful. And we are always available. The heart failure transplant team is always available. If they have a question, they always can lift and call us. And if there is a need, we can come in and put it bedside. These are simple procedures. As I told you, like, nobody dies because of this procedure. Trust me, nobody dies. Unless and until you are really bad and want to kill somebody, you cannot kill somebody with this device. So you put it in. The next question is, who is going to look at the numbers? So if you're not comfortable, you transfer the service to people. That's why I said preferably CCU, where people are used to. And again, I have, and we are working towards getting the CCU more run by people who know the numbers rather than everybody in the world coming to CCU and rounding. Because CCU is one place. When I say CCU will take Swans, everybody who is coming to CCU as an attending should be familiar and willing to do this technology, adapt this technology. And if in doubt, call, because there's no shame in asking. Shame is when you don't ask and something happens wrong. So I think people should go back into this technology, and there should be some more standardizations which we need so that everybody is comfortable with the numbers they get. And when in doubt, ask.
All right, thank you very much.
Thank you. Thank you, sir.
I like your restart.